Okay, I think we can get started. Um, okay, so it's my pleasure to introduce Dr. Kevin Bennewith as our speaker today. Kevin is a distinguished scientist at BC Cancer Research Institute and a professor in pathology and laboratory medicine at UBC. His research interests include studying how the solid tumor microenvironment affects cancer therapy response, tumor cell invasion, and the development of tumor metastases. And his group is also interested in the influence of poorly oxygenated tumor cells, stromal cells, and immune suppressive cells in primary and metastatic tumor growth. So look forward to hearing what Kevin has to say today, and I'll turn it over to you.
Great. All right. Thanks very much, Will. And I wanted to thank the organizers too. This is my first time talking at Pathology Rounds, and I'm quite excited to show you some of the stuff we've been working on. We're going to talk about some stuff that was published a few years ago, but then there's also the second half of the talk is a bunch of unpublished data that we're going to be talking about today. And thank you for tuning in wherever you are, even though it's a nice sunny day outside. So as Will mentioned, this is a talk we're going to talk about these angiotensin receptor blockers. So this is a new research interest for us, probably in the last 5 years or so. And I hope to convince you by the end of the talk in terms of our learning objectives that were circulated, the potential off-label, if you like, phenotypes that can be induced by some of these angiotensin receptor blockers. And we're really looking at them in the context of using these drugs as adjuvants for potential radiation therapy or immunotherapy of cancer. And so one of the first things I need to do is make sure that this is going to actually advance for me. There we go. So because this is my first rounds, I wanted to give just a little bit of an overview of the stuff that we do in my group. So we're very interested in what's happening within the solid tumor microenvironment. And so this is the microenvironment that exists within many solid tumor types. So can include a variety of different molecular, cellular, and physiological factors that can influence cancer therapy. Here's a section of a tumor. We'll talk about some of the colors in a couple of different slides coming forward. But essentially, we're looking at things that influence tumor perfusion and oxygenation level of tumor cells and other cell types that are in the solid tumor microenvironment. We have an interest a little more recently in cancer-associated fibroblasts and how all of these different factors kind of come together in order to mediate treatment response, be it radiation therapy, chemotherapy, or surgery, and also immunotherapy as well. We're interested as well in local invasion and distant metastases. So this is some of the work that was done by Lisa Ducotre. So she recently graduated. She was a pathology graduate student, left just us a couple of years ago. And some other work in the lab, we're also interested in the process of metastasis in distant tissues. So this is where some different immune cell types, be they immune effector or suppressor cells, can accumulate in distant tissues, such as the lungs, for example, or in the brain. And you can see a list of the different immune cell types that we study there. And that can really set up these permissive environments for metastatic tumor cells to take up residence. And I think anybody that's heard me speak before, I've probably been talking a lot about that aspect of our lab. But today, we're going to be talking about a lot of stuff in the red box here, which is what's happening mostly within the primary tumor environment. We're going to put the metastasis research to the side just for today. And so just by way of an introduction, so the tumor hypoxia or poorly oxygenated tumor cells, it's been known for many decades now that patients that have hypoxic tumor cells in their tumors do a lot worse after therapeutic intervention. And so some of the earliest work was using a PO2 electrode where they actually take oxygen measurements within the primary tumor. And this is a cervical cancer cohort published in 2002. Patients with more hypoxic tumors do worse after radiation therapy. But since that time, there's a lot of other groups that have looked in using not just radiation therapy and not just cervical cancer, but other cancer types as well. This is a paper about soft tissue sarcoma being treated with chemotherapy. Carbonic anhydrase 9, you may have heard of that from Shaukat Dedhar's group at BC Cancer. So this is also a protein that is upregulated in hypoxic tumor cells. So expression of CA9 is an indication that you have hypoxic cells in your tumor. And so those patients do worse after disease in terms of disease-free survival after chemotherapy. There's also some work that was published that patients with more hypoxic tumors do worse after surgery as well. And this is a local cohort. So this was a breast cancer patient cohort published by the Dedhar group in 2011, showing again that patients with hypoxic tumors do worse after therapy. And so just to give you a bit of an introduction into what tumor hypoxia can be, so it arises through an imbalance in terms of oxygen supply and demand. So on the left-hand side of this cartoon, this is one depiction of hypoxia that we call chronic hypoxia. So this is where there's a limitation in the ability of oxygen to diffuse through tumor tissue. And so that you get these tumor cells that are at a distance from these blood vessels that have very low PO2, and that's kind of depicted in this cartoon right here. So these blue cells here are hypoxic. They're functional. They're still viable. They don't tend to be proliferative, but they can certainly come back and repopulate a tumor during or after therapy. There's another type as well, this transient or acute hypoxia. So this occurs when you get an occlusion of a blood vessel, and that can happen from a variety of different ways. We'll talk about that in a couple of minutes. And so these vessel occlusions can cause changes in red blood cell flux over time. And what you see if you were to plot this, you can see a change in PO2 levels as a function of time. So these are blood vessels that become more or less functional as a function of time, which can be a real problem during short-term therapies like radiation therapy. So because of this, there's been many strategies that have been developed in order to improve tumor oxygenation. And these include patients breathing hyperbaric oxygen or carbogen. There's a lot of blood flow modifying drugs as well in order to try to increase perfusion of tumors, particularly in the context of radiation therapy. Some of these have worked moderately well here and there in clinical contexts, but there hasn't really been that much of a home run in terms of changes in standard of care. So the carbogen data actually looked quite good, but there were some issues with that. We can talk about in the question period if anybody's interested. So what we are actually going to talk about today is whether there's a different class of compounds, the renin-angiotensin system inhibitors, that could be useful as potential adjuvants for radiation therapy. So I have to take one step back and tell you a little bit about the renin-angiotensin system. So for those of you that are unfamiliar, the renin-angiotensin system regulates systemic blood pressure and fluid electrolyte balance in the body. So angiotensinogen is a protein that's produced primarily by the liver, and it gets cleaved into angiotensin 1 by the enzyme renin. So renin is produced when the kidney senses decreased renal blood flow. And so what this does is it cleaves angiotensinogen into angiotensin 1, which can be further processed into angiotensin 2 by the action of these angiotensin converting enzyme, which is typically expressed in endothelial cells in the lungs, but also in other tissues as well. And so angiotensin 2 is the signaling component, one of the signaling components of this kind of pathway. So angiotensin 2 interacts with the angiotensin 2 type 1 receptor, or AT1R. And what this does is this leads to increased blood pressure, vasoconstriction, and aldosterone production from the adrenal cortex. And so this is what's happening on a regular basis whenever the body senses a drop in blood pressure in order to increase blood pressure. That happens through angiotensin 2 response. But this can actually be aberrantly regulated. And so in patients that have high blood pressure, there's a couple of different compounds that have been, or compound classes that are used to treat hypertension. One of them is the ACE inhibitors, which inhibits the activity of the angiotensin converting enzyme. So that blocks the production into angiotensin 2. And there's also AT1R blockers, which we're going to focus on today, or ARBs. So these are compounds that actually prevent angiotensin 2 from binding to the AT1 receptor, and it can actually limit the downstream signaling downstream of AT1R. So all of this to say that this does lead to a decrease in blood pressure. However, the AT1R is expressed on a number of different cell types, and there's actually other functions that are known for the AT1 receptor as well, beyond just regulating hypertension and heart failure and cardiovascular risk reduction. So these drugs are used for other things as well. So the AT1R, it's a G protein coupled receptor. It's expressed on a variety of different cell types, and it can do a lot of different things. And so we're just going to do a kind of a broad bird's eye view here. So angiotensin 2 can actually bind to the AT1 receptor, which is right here. It can induce calcium mobilization and reactive oxygen species generation. It can be involved in the activation of a variety of different signaling cascades downstream. But overall, in the context of wound healing and in the context of cancer, which is what we're going to focus our discussion on today, it is known to promote angiogenesis, so the formation of new blood vessels, and it can also be involved in extracellular matrix remodeling, or particularly collagen deposition. And so for this reason, ARBs have actually been prescribed as antifibrotic agents as well, and have been prescribed for patients with heart, liver, or lung fibrosis. And so the main target in this context, in terms of collagen deposition, is the fibroblast population, because as many of you probably know, fibroblasts are major producers of collagen. So what happens during the process of wound healing or inflammation is these fibroblasts that are in a non-activated state throughout different tissues can actually upregulate the AT1 receptor. So angiotensin 2 systemically can then bind to the AT1 receptor, and the fibroblasts then start to produce thrombospondin 1. And thrombospondin 1 can convert inactive TGF-beta in the extracellular matrix into active TGF-beta, which then works in an autocrine loop to lead to proliferation and activation of these fibroblasts into like a myofibroblast, like activated fibroblasts. This leads to increased alpha smooth muscle actin expression, collagen deposition, and extracellular matrix remodeling. Again, this happens within the context of wound healing primarily. There's also a large body of literature showing that these fibroblasts can actually be, when they're in the solid tumor microenvironment, they are termed cancer-associated fibroblasts, and they can actually exhibit a lot of these same phenotypes. So they can have increased alpha smooth muscle actin expression, increased collagen deposition, and extracellular matrix remodeling. And this is, the best example of aberrant cancer-associated fibroblast activity is probably pancreatic cancer, where there's this well-known fibrotic or desmoplastic response, and that's all being driven by the cancer-associated fibroblast population. And so knowing this, Rakesh Jain's group about 12 years ago postulated that if they were to inhibit the activity of the AT1 receptor using an angiotensin receptor blocker, perhaps they could change the activation of these fibroblasts and the activation of cancer-associated fibroblasts in particular, and lead to a decrease in collagen deposition in some of these tumor models. And that is indeed what they found. So they used the angiotensin receptor blocker losartan and found that if they blocked the AT1 receptor, that they got a decrease in collagen deposition in the tumors. A couple of years later, they actually published an additional few papers, and they looked at the influence of collagen deposition, this dense desmoplastic reaction, on the constriction of blood vessels. And they postulated that if they were to treat tumors with losartan, that they would actually decrease collagen deposition, and that would reduce the blood vessel compression and increase tumor perfusion and drug delivery. So they were focusing primarily on the context of chemotherapeutic development, but we looked at these data and thought, is there going to be an effect on hypoxia or radiation response? This is very similar to what we had seen before with our transient hypoxia in some of our tumor models. And so we wanted to ask the question if these angiotensin receptor blockers could be used to increase oxygen delivery to the tumor and also affect radiation response. So one of the first things that we did is we screened a lot of our human tumor xenograft lines. So the Witter is good. We're going to come back to that one quite a bit for reasons that'll become clear in a little while. A Witter is a human colon adenocarcinoma. We have a couple of different head and neck lines as well. And then these 3 cell lines here are all cervical cancer cell lines. And the only thing that I want you to take away from these plots is that there is a large difference in terms of alpha smooth muscle actin expression. Alpha SMA in this context we've used as a marker of cancer-associated fibroblasts. And you can see right away that there's a large difference in terms of the amount of green staining that we have here, and it could be quantified here as well. We have some tumor lines that don't express alpha SMA at all, or don't contain alpha SMA positive cells, whereas others contain a fair proportion. And you can see that there's a difference also in the collagen area between these different tumor lines too. And one of the issues with this, alpha SMA works fairly well for immunofluorescent detection of fibroblasts. However, it's not an exclusive fibroblast marker. So alpha smooth muscle actin can be expressed certainly on myofibroblasts, but it's been appreciated primarily in the last 5 years or 5 to 10 years or so that CAFs are actually a heterogeneous mixture of fibroblasts. So they can have different cells of origin, different cell surface markers. They can have different phenotypes and functions that can affect tumor growth as well. And this is probably best exemplified by Fatima Mekta-Gregorio's group back in the late teens and early 20s, where they looked actually in patient samples, and they found that they were using multispectral flow cytometry and single cell RNA-seq. They found that there was a lot of different CAF subsets present in primary breast tumors and metastases, lymph node metastases from those breast tumors as well. So initially they identified 4 different CAF subsets. And since that time, there's been a lot more that have been identified. It really depends what technique you use and how close you look in terms of distinguishing between different subsets as to how many you'll see. But for our purposes today, we'll just stick with these 4. So the CAF subsets that have been identified, there's myofibroblast-like CAFs, there's inflammatory CAFs, there's antigen-presenting CAFs, there's vascular CAFs, a whole lot of different ones that are identified by different markers and different functions. And so we were interested in whether CAF subsets existed in our xenograft models for starters. So this is some work done by Chi-Min Lee in my group. And so she, first of all, took a look at the Witter tumors, and she disaggregated them and gated out EpCAM. Fortunately for us, the Witter tumor cells express EpCAM, so we're excluding those from our analysis, and also CD31 and also CD45 to get rid of any normal cells that are in there. And then she went through a fairly extensive search for different markers, and she's settled on photoplanin and CD29 as an indication that as a way of discriminating between different subsets of these cancer-associated fibroblasts. And you can see right there the different markers that we've used, and she's excuse me, named these S1 through S4. And so the just to give you first comparison to some of the other CAF markers that you may have heard of, fibroblast activated protein, or FAP, the expression between these different CAF subsets was actually quite variable, so we couldn't use that as a very good indication. And you can see here the MFI is actually quite low. Alpha smooth muscle actin is expressed primarily by the S1 and the S4 subtypes, which are these ones up here. So those are CAFs that express photoplanin and CD29. Collagen 1 we found was expressed by all the CAF subsets, at least at the mRNA level. You can see the S1 CAFs produce relatively the most of it compared to the other CAF subsets. And then when you look for the AT1 receptor, you can find that the AT1R is expressed primarily again by this S1 CAF subset. Just one word of note here, these are all qPCR data, and that's because the Western antibodies for AT1R are not the best. And so there's, I believe, 3 people in my group right now working to try to identify the best AT1 antibody for Western blot and for flow cytometry. So for now, we're restricted to just looking at the qPCR level. So the take-home message from this slide is that these Witter tumors contain a lot of S1 and S4 CAFs, and the S1s seem to express the highest level of collagen and express AT1R, at least at the mRNA level. So you can look at this in the other tumor lines that we talked about. So the Witters, but also the ME180, which is a cervix line, FATU, which is a head and neck, and CHA, which is another cervix line. And you can see right away that there are distinct differences between the S1 fraction between these different tumor types. And so you can quantify the total number of CAFs in these different tumor lines. And we looked in 6 altogether, and calculate the total number of collagen producing S1 CAFs in all these different lines. And we basically did a rank order so that we could identify tumors that would contain a high level of these S1 CAFs down to a low level. And so the ones that are in bold here are the ones we're going to talk about a little bit more. So these are the Witters, the ME180s, and the FATUs, and the CHAs. So what we did then is we implanted the tumor lines, and we wanted to test the effect of the angiotensin receptor blockers losartan and telmisartan on the tumor microenvironment. So we wanted to look at collagen, perfusion, hypoxia, and ultimately radiation response to see if these ARBs would be effective as adjuvants for radiation therapy. So the first thing, we'll just walk you through the data here. So the alpha SMA expression, you can see there's a lot of alpha SMA positive CAFs in the Witter tumors. And again, there's no detectable ones in the CHA tumors, maybe one right there. But in general, there's no alpha SMA positive CAFs in those tumors. If you have these mice, so we give these angiotensin receptor blockers ad libitum in the drinking water. And so these mice that are on losartan and have their Witter tumors implanted, there's no effect in the alpha SMA positive fraction. Telmisartan we've used as well in addition to losartan. So telmisartan has a modest effect on the level of alpha SMA positive cell fraction or area within the tumors. And you can see the fluorescence intensity is a little bit less. I'll show you some flow cytometry data in a minute to be a little more convincing. Just a quick word on telmisartan. It is kind of a newer generation angiotensin receptor blocker. Losartan was a very early generation. Telmisartan is more recent. It has a much higher AT1R binding affinity, a longer biological half-life as well. And so we think it is a lot more potent of an angiotensin receptor blocker than losartan. So that's why we moved in that direction. So, and as you can see, there was no effect in the CHA tumors. If you look at the CAF subset frequency, so these are between mice that were not treated with telmisartan or treated with telmisartan. There's no effect in terms of the distribution of the S1 through S4 CAF subsets, so those stay constant. However, you can see here by flow cytometry, looking at the mean fluorescence intensity, that telmisartan treatment actually does decrease the level of alpha SMA expression on the S1 and S4 cancer-associated fibroblasts. And so this is something similar to what Rakesh Jain's group had shown with losartan, but we're using through telmisartan, we can see that there is a decrease in the alpha SMA positive expression on these CAFs, which is suggestive of a decrease in their level of activation. So what we wanted to do next is look at the collagen deposition, because that's really the functional readout of these CAFs. And so first of all, here we have collagen 1 in red. So you can see right away that the Witters have a more dense collagen-rich extracellular matrix in their tumors compared to the CHAs. There is still certainly collagen there in the CHA tumors, but it's not quite as intense in terms of a staining point of view. And when you treat both tumor lines, either with losartan, we didn't see any effect. So losartan tumors still have a fairly high level of collagen 1. It's quantified down here. But when we treat with telmisartan, now we can see that there's actually a drop in the level of collagen throughout the tumor, which can be quantified down here. Whereas in the CHAs, these are the tumors that, again, don't have this S1 calf population. We see no effect on the collagen levels in that line. So we next wanted to know if this decrease in collagen deposition that we can see in these Witter tumors treated with telmisartan, can that actually change tumor blood flow? So we went back to this method that we had developed. So this work was done in collaboration with Koshin Lin's group and Francois Bernard's group here at BC Cancer. And so we had fluorinated ethanol, and when you inject that intravenously, it gets taken up into the tissues throughout the mouse in proportion to blood flow through that tissue. And so we did this, published a paper in 2017 looking at this in the context of solid tumors. So just to orient you very quickly, this is just a PET image of a mouse that has two different tumors. The one is the 67NR, which we know is a very highly perfused tumor. There's no hypoxia in it. There's lots and lots of vessels, lots of blood flow. And the 41 is the opposite. It's quite a hypoxic tumor, not a lot of blood flow. So if you do a dynamic PET scan after injection of the 2-fluorinated ethanol, then you can see that the 67NRs are a lot more perfused than the 41s. And so we actually in that paper looked at whether this can be used to predict or identify changes in perfusion based on drugs, and it can be. So we did that with our telmisartan. So you can see this is a cross section now of the mouse with the tumor identified in red. So this is the CT scan and the PET scan below. And I hope you can appreciate right away that in these mice that are treated with telmisartan, the Witter tumors have a lot more uptake of the 2-fluorinated ethanol, which is indicative of an increase in tumor perfusion. And this can be quantified in these dynamic PET scans here as well. So telmisartan increases the level of uptake of this radio tracer. And again, there's no effect in these CHA tumors, as we would have predicted. So the other thing we wanted to look at is based on immunohistochemistry, whether we can see a change in terms of perfused blood vessels. So Hooks 33342 is something that we've used for decades in the lab. If you inject this perfusion dye intravenously and allow it to perfuse the tissue for 10 minutes, then it can actually indicate vessels that are perfused during the circulation lifetime of the agent. And so the perfused fraction of CD31 positive vessels in telmisartan treated Witter tumors does increase. And so this is kind of consistent with what our hypothesis was. So if you change the level of collagen deposition, you can actually increase bulk tumor perfusion, and that can be identified here with the Hooks injected as well. And again, with the CHAs, we don't see any effect. There's one other characteristic of solid tumors that we were interested in studying, and this goes back to some of the work that I did during my PhD, is looking at this transient hypoxia that I introduced at the beginning. And so one of the methods for that, Andrew Minchinton from BC Cancer helped to pioneer this sort of technique, where you can inject two different perfusion dyes separated in time, 20 minutes apart, and that gives you an indication of vessels that have changed their perfusion status within that 20-minute window. And so here there's what's circled in red here is an example of a blood vessel that was functional at this point in time, and then not functional when the carbocyanine came in 20 minutes later. So you can actually quantify this, and this was some work done out of Peggy Olive's lab by Martin Trotter a number of years ago. And what you can do is you can quantify the level of mismatch throughout the different tumors, and you can quantify the fraction of vessels that have either a dramatic change in intensity between the two perfusion dyes or not. And so what we are showing here is that there's with the telmisartan treated tumors, there's an increase in the number of vessels that have stable perfusion, and there's a decrease in the proportion of vessels that have a big difference. And so what this is indicative of is stabilization of this microregional perfusion. So this is very suggestive of a decrease in perhaps transient hypoxia, but I'll show you data on the next slide that's corroborates this. So this is a cross section now of a Witter tumor. Oops, sorry. Cross section of a Witter tumor that has not been treated with anything. You can see red here is CD31, blue is this Hooks that's injected intravenously, and green, this is pymenidazole. This is a drug that is bound and retained in cells below a given oxygen tension. So it's a well-established marker of hypoxic tumor cells. And so this is very indicative of what we see from that chronic hypoxia I told you about at the beginning. You have a perfused vessel, and then there's a distance of viable tumor tissue, and then there's a region of pymenidazole positive hypoxic cells adjacent to necrosis, which is indicated by the stars here. What's also I wanted to note is that there are evidence of CD31 positive vessels that have no perfusion, so don't have blue surrounding them, and they're actually in these hypoxic areas. So these are blood vessels that are indicative of vessels that have no function, and there's hypoxia surrounding them, so there's no oxygen delivery, and so this is very indicative of transiently hypoxic regions surrounding these blood vessels. So and that's indicated with the yellow arrows. So in the telmisartan treated tumors, I hope you can appreciate it's quite a different story. So we do have a lot more perfusion. So there's a lot more blue coming from the hooks, a lot more perfused blood vessels. There's also, there is still hypoxia present, and this is the chronic hypoxia. Remember that there's a perfused vessel here, distance, oxygen diffusion is limited, and so then you get hypoxic regions. But what we don't see is these blood vessels that are in these hypoxic tumor regions. I managed to find one right here, but in general, we don't see blood vessels that are hypoxic. So that suggests that the transient hypoxia was not detectable in these tumor models. And so you can quantify the total level of hypoxia in these tumors as well. And you can see the Witters decrease with telmisartan treatment, and so do the ME180s. But the FADUs and the CHAs, there's stable hypoxia between those two models, whether they're treated with telmisartan or not. And both of those tumor lines did not contain these S1 calf population. So the last thing that we did for this particular story is we wanted to see again if this decrease in hypoxia or increase in oxygen delivery could have an effect on radiation response. So oxygen is very, very well known to increase radiation response. Hypoxic tumor cells respond far more poorly to radiation than not. So the first thing I wanted to draw your attention to is the control in telmisartan treated mice. So in this was actually quite surprising to us, that telmisartan on its own, despite the fact that it's decreasing calf activation, it's decreasing collagen deposition, increasing blood flow, decreasing hypoxia, has absolutely no effect on tumor growth on its own, which I thought was actually quite surprising. So that those two curves sit right over top of each other, whether it's the Witter or the ME180. When you irradiate these mice that did not get telmisartan, when you irradiate them, you see a tumor growth delay, which is as we would expect. This is after a single dose of 10 gray. And when you have the combination, so this is where you've irradiated tumors in mice that are treated with telmisartan, you can see that there's an even more dramatic delay in this tumor growth. And this is after single fraction radiation. So this is the averages of all the mice in the group, or you can express this as a Kaplan-Meier plot down below too, at least in terms of looking at the response of individual mice. And you can see that there's an increase in the growth delay induced by radiation plus telmisartan treatment, particularly in the Witter tumor models. And just to kind of make sure that this is something that is affected by the solid tumor microenvironment, we did some experiments in vitro where we irradiated these Witter tumor cells with and without telmisartan, and we found that there was no influence on the clonogenic survival. So this is indicating that telmisartan did not directly sensitize tumor cells to radiation. And then we also just data that I'm not going to show you because it's negative, and in the interest of time, there's no effect of the radiation response of FADU or CHA tumors to this as well. So if you treat those tumors with telmisartan, you don't see any changes whatsoever. And that's consistent with the lack of S1 CAFs in that tumor model. And so just to summarize the first half of the talk, and if you're interested in learning more about this, this was published by Brennan Wadsworth. Brennan was actually another pathology and laboratory medicine grad student who graduated during COVID. He's currently at the Karolinska Institute in Stockholm. So this paper kind of summarizes a lot of the work that I've just told you about. So just to summarize this part, there's 4 different CAF subsets that Ximin identified in these human tumor xenografts. They have variable frequencies between the different tumor lines. It doesn't seem to be associated with tissue of origin. It seems to be kind of all over the map. In terms of telmisartan treatment, it can definitely decrease collagen deposition and increase tumor perfusion, and ultimately stabilize microregional perfusion in solid tumors. This leads to a decrease in hypoxia, less pymenidazole staining, and improved radiation response. But it seems to be restricted to tumors that contain this photoplanin mid CD29 high population of S1 cancer-associated fibroblasts. Because we didn't see that telmisartan had any effect on the microenvironment of these other tumor lines that don't contain those S1 CAFs. And so and you can see it's all indicated in the cartoon here. And so the next question that we had is we wanted to know, this is all well and good, but everything done here was in a human tumor xenograft context. And so we wanted to know whether telmisartan would have any influence on tumors that are grown in immunocompetent mice. So all, of course, these being human tumor xenografts, they were all grown in NSG or NRG immunocompromised mice. And so Meredith Clark in the lab has been working on this project now for a little while, 6 months or so. And so one of the first things that we did, and this was Kirsten Thomas when she was in the lab, produced this first couple of plots. And so we simply implanted EO771, which is a murine mammary carcinoma line. We like it because we can implant these tumors orthotopically into the mammary fat pad, and we can monitor tumor growth within the tissue site of origin. And so when you implant these EO771 tumors into the mammary fat pad, and you give these mice telmisartan in the drinking water from initial tumor implant, you can see that you can see single agent activity. So this is something that we had not seen in any of our xenograft models before. Excuse me. So that telmisartan just on its own can decrease the tumor growth of these EO771 tumors. And so interestingly, we wanted to try to relate this back to some of the work that I just told you about. So one of the things that we did was we implanted the exact same EO771 tumors in immunocompromised mice, and we found that the telmisartan had no effect. And so this was suggestive to us that the black 6, the tumor line was the same. So there's something unique about the black 6 background compared to the NRG background. First thing to look at, of course, is the presence of an immune system. So first of all, we're gonna show you a little bit of data. This was generated by Lisa Zahn in our group. So what Lisa found was that telmisartan did not significantly affect perfusion of these EO771 tumors. So these are tumors that are control, so no treatment or telmisartan treated. And these are all EO771 tumors, be it 15 days after implant or 22 days after implant. And if you quantify these data, you don't see any change in perfused blood vessels with telmisartan treatment in these EO771 tumors. So it's not the same as we saw in the Witter tumors. And this can be backed up. This was some work that Chi-Min Lee did. And so EO771 tumors actually have a very low proportion of these S1 CAFs. They do express alpha smooth muscle actin, but there's a low proportion of them. So this would be one of those tumor lines that we would expect perhaps would not be responsive to telmisartan on its own through that collagen-based mechanism. So the next thing, again, we repeated this experiment a number of times. So this is some of Meredith's data now. And we see the same thing, that single agent telmisartan can definitely delay primary tumor growth in this line. So what Meredith did at that point was she started to look at the immune cell composition within these primary tumors. And we've done it at day 15, which is close to when the tumors haven't quite started to split off yet. We've also done it at day 22, 23 at endpoint. And so first thing to notice is that whether you've treated the mouse with telmisartan or not, there's no change in the B cells, NK cells, our conventional CD4 helper cells, or CD4 positive regulatory T cells. But we did see an increase in CD8 positive T cells. And so this kind of obviously piqued our interest. So CD8 positive T cells can be responsible for attacking and destroying tumor cells, and they could certainly be responsible for delaying this tumor growth in this line. But just because the T cells are there doesn't mean they're actually capable of doing much of anything. So we have to look at activation first and foremost. So one thing to note here, this is the same data I just showed you, but it's expressed in 2 different ways. So this is the percentage of total CD45 positive cells that are CD8 positive T cells in the primary tumor. And you can see with telmisartan treatment, we see an increase in the proportion of those leukocytes that are CD8 positive T cells. And just to be sure that that was not a function of the fact that these tumors are significantly different sizes at that time point, we went back and normalized these data to quantify the number of CD8 positive T cells per milligram of tumor. And we found that indeed these telmisartan treated tumors, even though they were smaller, they had a higher proportion or higher number of CD8 positive T cells per milligram of tumor. But again, just because there's more T cells there doesn't mean they're doing anything. So Meredith then went ahead and started looking at some canonical markers of T cell activation. And so CD44 is an indication of antigen experienced T cells. And you can see that these T cells that are in telmisartan treated tumors have an increase in the CD44 positive fraction. And this can actually as well be converted into the number of activated CD8 positive T cells per milligram of tumor. And there's also an increase in PD-1. So just a quick word on PD-1. It is, of course, very well known as an exhaustion marker, but first and foremost, it is a marker of T cell activation. And so in this context, we're going to get to the exhaustion stuff in a couple of slides, but at least in this context, we're using it as an indication of an activated T cell phenotype, particularly in conjunction with CD44. So not only does telmisartan increase the proportion of CD8s in these tumors and the number of CD8s in these tumors, but those T cells are also tend to be more activated. And so we were wondering if this made telmisartan as a potential candidate for combination with anti-PD-1 therapy. So we just have to put a little pin in that just for a moment. We're going to get back to that kind of towards the end of the talk. So I'm going to leave you with that just for a moment. But what we're going to take a look at next is we really wanted to know what telmisartan was doing to the T cells. So why is it that telmisartan can increase the activation status of these T cells in vivo? And so in order to do that, we have a long-standing collaboration with the Ramon Klein-Geltink lab, and he is very kind enough to share their protocols for T cell activation with us. And so we've been doing a whole lot of work in that context now. And so what Meredith has done is you can take, excuse me, you can separate CD8 positive T cells out of C57 black 6 spleen. So these are all naive T cells. And you can put them into a plate. You can polyclonal stimulate them with anti-CD3 and anti-CD28 in the presence of IL-2. 48 hours later, you split the cells, and you just have IL-2 for another 24 hours. And then, excuse me, and then you can re-stimulate them again with CD328, and you can look at the production of effector molecules or production of cell surface markers as well that are indicative of T cell activation. And so for these experiments, we had telmisartan on board the entire time because we were trying to model what we had in the mice. And so the first thing to note is that telmisartan does not seem to affect overall CD8 T cell viability. There may be an effect on proliferation. We do see a change in the fold increase in CD8 T cells after this time period, particularly at these higher doses. Just for those statisticians on the call, when we do these experiments, we do them with an N of 3 biological replicates, but then we repeat them a number of different times so that we can have more robust comparison. This is just an example of one of the 3 biological replicates in a single experiment. So in terms of doses, I think it's important to take one quick step back because we weren't quite sure whether 50 micromolar is that a high dose or a low dose. And so one thing that Meredith did in collaboration with Kevin Sun and Marcel Bally's group is she was looking at the concentration of telmisartan in the bloodstream of the mice. And so I think this is a really important thing to do so that we can be sure that what we model in vitro is actually indicative of what we see in the mouse. And so this is either on day 15 or day 22. These are all tumor-bearing mice. So these are mice that are bearing the EO771 tumors, and you can see the approximate concentration of telmisartan in the serum in terms of micrograms per mil. And this translates into around 3 micromolar, 3 to 4 micromolar telmisartan in the circulation. And so now telmisartan can accumulate in tissues, but unfortunately there's some technical challenges looking at the actual telmisartan concentration in our tumors. So I can't give you an exact concentration for that at this point, but at least we know that in the circulation, that level is about 3 micromolar. So that's kind of our foundation, that's our basement. And we should be looking at that level and up from there. So the other thing to note is that when you do treat these T cells, these are again polyclonal stimulated ex vivo CD8 positive T cells. You can see in the presence of telmisartan that you have an increase in CD69, which is another indication of T cell activation. And again, PD-1 as well goes up in these T cells as well. So this is another line of evidence suggesting that even when you're not in a solid tumor, if you just have polyclonal restimulation of these CD8 positive T cells in the presence of telmisartan, you get an increase in expression of these T cell activation markers. But activation markers are not the whole story. So we really wanted to look at production of effector molecules from these CD8 positive T cells. And this is some work that was done by Michael Hall and Kirsten Thomas in preparation for a grant, I believe, that we submitted a while back. So just to walk you through these data. So these are these T cells that have been activated, and they've been activated and expanded and then not given that second re-stimulation. So this is very typical of what we see in T cells that have not been re-stimulated. You don't see very much in the way of interferon gamma or TNF alpha, these effector molecules. Granzyme B is a bit of a funny one. There is a basal level of granzyme B expression in naive T cells. or T cells that have only been stimulated once. In this context, we actually treated these cells the whole time with angiotensin 2, which in order to stimulate the AT1 receptor, telmisartan in order to see what effect that has, and then the telmisartan plus angiotensin 2 was to try to see if there was any effect of Ang2, if that would be blocked by inhibiting the AT1R through telmisartan. What was a little bit surprising, and you'll see it more clearly when I animate the rest of the slide, is that we didn't see any effective angiotensin 2, but telmisartan itself seemed to increase the proportion of granzyme B positive T cells in this. And this is again in the absence of restimulation. So what we normally see after the restim is that interferon gamma, TNF alpha, and granzyme B, and so this is just comparing the purple to the purple, those all are increased. This is very typical of what we see. When we had done this in the presence of angiotensin 2, we didn't actually find any difference. And so this was suggesting to us that angiotensin, provided we have enough concentration of Ang2 in the system, this Ang2 via AT1 receptor activation does not seem to change the effector molecule production of these T cells. So when we did this just with telmisartan, we had a bit of a surprise. We found that telmisartan was able to increase the effector molecule production. So again, blocking a drug that is known to block the AT1 receptor is all of a sudden increasing effector molecule production, but it doesn't seem to need angiotensin 2 there at all. And so what this said to us, and again, this is comparing essentially telmisartan in the stimulated conditions here, the blue compared to the purple, and whether you had angiotensin 2 on board, there didn't seem to be any difference there. So what we have is a situation where angiotensin 2, which is known to activate AT1R signaling, doesn't seem to do anything, and telmisartan, which is known to block the AT1R, is doing something, which is really suggestive to us that there could be an AT1R independent function of telmisartan. And so this is where I have to come clean, because I didn't tell you the whole story about telmisartan when I started the talk. Telmisartan is known as an angiotensin receptor blocker. It is a very potent angiotensin receptor blocker, but it also has another function as well. So telmisartan is known to do all of these things in the terms of the AT1R signaling, but it is also can act as a partial agonist of peroxisome proliferator activated receptor gamma, or PPAR gamma. So PPAR gamma is a heterodimeric transcription factor. It's ligand activated, so when the ligand binds to PPAR gamma, it heterodimerizes with RXR, and it is responsible for the transcription of a variety of different genes. Primarily, these PPARs, there's 3 different members of the family: PPAR alpha, PPAR delta, and PPAR gamma. Those have been studied mostly within the context of diabetes research because they're definitely involved in glucose and lipid metabolism, and they can affect insulin sensitivity as well throughout the body. And so in terms of PPAR gamma, again, this is a transcription factor. And so this is one of those things that has been actually studied quite extensively in different tissues, different cell types. In the literature, however, it was kind of interesting that most of all of the data that we could find, there's a role for PPAR gamma in CD4 positive T cell function, but we really couldn't find any information at all on whether PPAR gamma can affect CD8 positive T cell function. There's an extensive literature on how PPAR alpha and PPAR delta can affect CD8 T cell function. So if you increase activation of either of those transcription factors, CD8s do a better job at killing things. But in terms of PPAR gamma, we really haven't seen anything in the literature on that. So this kind of piqued our curiosity as well. So just to prove to you just to show you some data that was published not by our group, but a number of years ago now. So telmisartan is known to activate PPAR gamma. This is just a reporter construct. This is in comparison to some of these other angiotensin receptor blockers: irbesartan, candesartan, valsartan, olmesartan, and eprosartan. Easy for me to say. And also losartan. So EXP3174 is the active metabolite of losartan. So this is essentially using losartan, and you can see that there's a massive difference in terms of the ability of telmisartan to activate PPAR gamma compared to these other ARBs. When you compare it to rosiglitazone or pioglitazone, which are full agonists of PPAR gamma, it doesn't do quite as good a job, about 30% of the activity. But suffice to say that telmisartan does have this dual agent activity of blocking the angiotensin receptor and also activating PPAR gamma. Again, as I mentioned a moment ago, there's really not much at all known about PPAR gamma and CD8 T cell function. And that's largely because PPAR gamma doesn't seem to be expressed in naive CD8 positive T cells. And I'm about to show you a Western blot that Meredith forbid me to show you because it is rather ugly, but she's on the other side of the world right now on the call, but on the other side of the world, so I'm going to show it to you. So she has shown that in these CD8 positive T cells that have only been stimulated one time and extended, that actually PPAR gamma is not really detectable. As soon as you give it that secondary stimulation, you see a dramatic upregulation in PPAR gamma. And so this is one of the reasons that we think that a lot of other groups haven't stumbled upon a role for PPAR gamma in CD8 T cell function, is because it needs to have this re-stimulation step in order to be upregulated. And so this is kind of laying a foundation for some work in the group now. So Meredith is going to be studying how functionally how telmisartan is actually affecting CD8 T cell phenotype, whether it is through AT1R inhibition or activation of PPAR gamma that is already upregulated. It's present in activated CD8 positive T cells. And we're going to be asking the question now, is telmisartan help to the PPAR gamma activity? So you'll have to stay tuned for that. We next wanted to look at telmisartan as a therapeutic intervention. So most of the data I've shown you so far has been telmisartan given at the time of tumor implant. So in order to use it as a therapeutic within the clinic, however, we have to be able to administer it after a tumor is already present. And so that's what's indicated in orange here. So we found that if we didn't give telmisartan on the day of implant, but we gave it on day 8, we can still have this reduction in tumor growth, a reduction in tumor weight at endpoint. We still have activation, increase in total number of CD8 positive T cells. We still have increase of activated T cells in terms of CD4 and PD-1 content as well. So this tells us that telmisartan can actually be used as a therapeutic intervention once the tumors have already formed. So then back to the PD-1 story that I was telling you about a little while ago. So those of you that are familiar with this, I'm sure, is that expression of PD-1, it is a marker of an activated T cell, but when it interacts with PD-L1, which is its cognate ligand, whether PD-L1 is expressed on a tumor cell or on macrophages, that can actually prevent the T cell from attacking and reduce its function. So there's immunotherapy, immune checkpoint blockade therapy is based on the concept that if you block this interaction, then all of a sudden you can take the brakes off of the T cell and it can then become active and it can attack tumor cells. And so what Meredith has done is she took again these E0771 orthotopically implanted tumors and treated them with or without telmisartan now 7 or 8 days after implant, and then started treating with anti-PD-1 therapy. So consistent with the literature, PD-1 at the doses, this was every 3 days. Consistent with the literature, the E0771 tumors are not very responsive to PD-1 at all. If you give PD-1 alone, you don't see any change in terms of tumor growth. Consistent with what we saw before, if you give telmisartan alone, you do see a growth delay. And then the combination is what we've really gotten excited about, is that if you give the telmisartan treated mice the anti-PD-1 therapy, you can see that there is actually a dramatic increase in tumor growth delay. So this really tells us that the combination of telmisartan along with anti-PD-1 has some real promise as an adjuvant therapeutic combination. And I'm going to have to, just in the interest of time, I'll just go through this reasonably quickly. So these are some of the T cells phenotypes that we saw kind of at endpoints in these mice. And so if you just look here, we'll just kind of walk you through it. So this is the control, and this is treated with an isotype antibody. Compared to that, with and without telmisartan, you can see in terms of CD8 T cell content, but there is an increase in mice that are treated with anti-PD-1 that is maintained here. So anti-PD-1 therapy does seem to also increase the proportion of CD8 T cells in these mice. In terms of activation, what we see is the telmisartan increases the level of activated T cells in these mice. And so that was consistent, but it's particularly notable when you do the combination therapy. So telmisartan combined with anti-PD-1 therapy, you see there's definitely an increase here in the proportion of activated CD8 positive T cells in those tumors, and we think those are responsible for clearing the tumors. Our next set of experiments is going to be to try to inhibit those CD8s, and just to make sure that that's the mechanism that we're looking at here. But whether you look at CD44 or 41BB, which are indications of activated T cells, you can see that those do go up in those mice. If you prefer looking at contour plots of flow cytometry that have been pseudo-colored, you can see that the control tumors here, there's a lot of, or the T cells, there's a lot of the purple ones, and when you get telmisartan and anti-PD-1 treated, they kind of move up into this double positive range. So these are indicative of an increase in activated T cells in those tumors. But I would be remiss to focus only on the lymphoid population. And so Meredith has a very strong interest in myeloid cells, and as do we. And so this is this is just some FlowSum plots showing similar to what I've shown you with the flow cytometry data. This is just a way of looking at all the different markers kind of all at the same time. And control is in light blue, and telmisartan treated is in red here. So this is kind of suggestive that telmisartan treated tumors have an increase in these CD1 positive cells. They've also seem to have an increase in these NK cells, which are here. But if you look at the myeloid compartment as well, using a variety of different myeloid cell markers, we've looked at granulocytes and eosinophils and monocytes and macrophages and monocyte-derived DCs. In the interest of time, we're just bringing that down to some of the more interesting data that we have, which is looking at changes in the myeloid compartment. And so this, what you can see here again is in these control tumors, we have a high proportion of these what are known as M2 or pro-tumorigenic macrophages, and those really shift into more of an M1 or anti-tumor macrophage subtype with telmisartan treatment. So that could be quantified here as well. This is a little easier to see. You can see this shift from a pro-tumor macrophage population to more of an anti-tumor macrophage population. We don't know if telmisartan is doing this directly. That's going to be future work, or if this is just a byproduct of the effectiveness of the CD8s that are in those tumors. So we're going to have to stay tuned for that as well. And just before I end the talk, I just wanted to make sure that you didn't think that we only studied mice. So there's looking at the role of angiotensin system inhibitors in cancer outcome. There was a meta-analysis of 55 retrospective studies published back in 2017. It was over 170,000 patient records, and they looked at people that were on angiotensin system inhibitors. These were ACE inhibitors or angiotensin receptor blockers. And it consisted of anywhere between 15 and 30% of the patient population. And the overall survival hazard ratio was actually favorable for patients who were taking these drugs. And this is across many different cancer sites and many different treatments. There was no focus on a particular type of treatment. It wasn't focused on radiation therapy, certainly not immunotherapy back in 2017. So what we wanted to do was our own analysis of this. So in collaboration with Sarah Hamilton at BC Cancer, she had a cohort that she published in 2020. It's just over 1,000 oropharyngeal head and neck squamous cell carcinoma patients, and about 7.5% of those were taking angiotensin receptor blockers. What was interesting to us is that the ARB users actually had disease characteristics that predicted poor outcome. So in terms of smoking status, HPV status, patient age, et cetera, the ARB users really would have been predicted to have pretty poor outcome, so much so that the control group, we couldn't just use the basic control group. We couldn't compare 81 patients to the remaining 900 and whatever it would be. So we did propensity score matching in order to balance the covariates between the ARB users and the control group of 81 patients. So this is the statistical method in order for you to make sure that you're comparing apples to apples and oranges to oranges as best as you can. And so when we matched the TNM stage and the patient age and the HPV status, smoking status, et cetera, and this was work done by Chi-Min Lee in our group, we found that there was a dramatic improvement in terms of local regional control and disease-specific survival. I think I've got that switched. So basically, ARB users had better local regional control. I switched these. ARB users had better local regional control and disease-specific survival than patients that were not taking ARBs. So in terms of a summary for this part of the talk, and for the whole talk, actually, so telmisartan is an angiotensin receptor blocker and a PPAR gamma agonist. Telmisartan can decrease collagen deposition and increase perfusion of tumors containing this S1 CAF population, which can actually affect radiation therapy response. Telmisartan also decreases growth of EO771 tumors, and we think that it's not through perfusion and collagen. We think that it's through increase of CD8 positive T cells within those tumors. And when you use telmisartan in combination with anti-PD-1 therapy, you see a dramatic increase in tumor growth delay. And so we think that telmisartan is actually unique in that it can be used as an adjuvant for radiation therapy or immunotherapy. And the data that I botched at the end is that head and neck cancer patients taking ARBs actually have dramatically improved overall survival and local regional control as well. So just by way of acknowledgement, so this was a lot of work done by Meredith in the lab. Michael Hall contributed as well as Chi-Min, Kirsten and Lisa as well. And some of the earlier work I showed you was from Brendan Wadsworth. So I just wanted to thank you for your attention and to our funders particularly. And I'd be happy to take any questions.
Thanks very much, Kevin. We'll open it up. We have, I guess, 3 minutes or so for questions. So we'll take a couple. Spencer?
Answer.
Sorry, can you hear me?
Yeah.
Yeah.
Thanks a lot for the talk. That was a great talk.
Hey.
Just wondering about the if you've looked at the vascular activation after the sartan treatments. Have you looked at T cell adhesion molecules, and then also have you looked at and compared to VEGF pathway antibodies and inhibitors to compare them to see if they're synergistic or if they're additive or?
So for the VEGF question, we have not directly looked. We don't think that these angiotensin receptor blockers can affect angiogenesis within our tumor models, and but we have not directly looked at that. We do think that it's related to collagen deposition, and some of that is based on the literature that has shown that you can actually phenocopy some of this if you just inject collagenase directly into a tumor in order to disrupt some of that collagen. But the important thing to note is that this does take a bit of time. And so one of the things that I kind of glossed over is that in order to see that effect on cancer-associated fibroblast activation and collagen deposition, that telmisartan has to be on board pretty early while those fibroblasts are coming in and being activated. And so that's why we were quite a little excited that within an immunocompetent mouse model system, you could actually see this being used as a therapeutic. So now all of a sudden, on the patient data was, again, patients that were on ARBs for some other indication, and they seem to do better after therapy. But now, within the context of immunotherapy, we think we can use telmisartan as a treatment, essentially. So we're very interested in that. Expression of other markers on the T cells, there's a lot of stuff that Meredith has looked at. And as you know, in particular, the more you look, the more you want to look. And so there's a lot more T cell markers that we have not looked at. We're focusing primarily on the activation and a little less right now on the recruitment mechanisms, but we do definitely think that there's something specific, because again, we don't see an increase in perfusion. So it's not that the T cells are coming in because we've opened more doors, more doorways into the tumor. There's actually something causing them to come into the tumor as well. So next steps as well, we're going to start looking at chemokine production by the tumor cells too, to see if that's how actually helping any influx of CD8 T cells or not.
Great. Okay, we have one more question, then we'll go. It's from Callum.
Oh, Callum,
chat.
have you looked at immune tumors due to immune cell exclusion, or would these change with the combined treatment? So yeah, the E0771 model is not what I would say immune cold. It's probably moderate. And we have not looked extensively at other Black6 based models. Some of it is by design. The B16 tumor model we have up and running, and it's a nightmare to work with in terms of ulcerations. But it is something that we want to do for Lewis lung carcinoma. We're planning to actually put those IV into the lungs, so they'll be orthotopically implanted, and then we could look in that context as well. But we haven't looked at other lines in the Black6 mice beyond the E0771s for now.
Great. Well, perfect. Thanks very much again, Kevin, for a great talk. And
I apologize for botching the clinical data.
yeah,
I literally put
we'll believe you.
I put a checkbox over top, and I must have just mixed them and didn't notice.
Okay. Well, I think this is the last rounds for a while, so we'll see everybody at the beginning of the academic year.
All right. Thanks, everyone.